Good morning, everybody. And to the Yankee fans, I'm sorry. What I'd like to do is to start off and talk about our host who helped set this all up today, Mr. Al Kinel. Quick bio on him. He is the president of Strategic Interest, a continuing, listen to me, I can't even read, consulting firm transforming healthcare. He works with providers, payers, collaboratives, and vendors to create a long-lasting positive impact through innovation. Strategic interest helps organizations update strategy, select vendors, win grants, and deploy systems that improve performance, enhance population health, and value-based payment programs. Interoperability is the key, is what they do. Prior to starting Strategic Interest, Al worked for global professional services firms and helped as a leader in technology management for Xerox and Kodak Health Group. In all his roles, he helped transform industries through innovative strategies and solutions, process redesign, and collaboration to break silos. Al is a strategist, community activist, pioneer, catalyst who helps stakeholders address their strategic interests while attending larger community goals. Al has played his role to introduce and support major initiatives in his community, all of New York and beyond. Al has actively helps many nonprofit and associations, including the New York State chapter of HIMSS, through events and sharing of best practices to advance the effective use of HIT. And I can tell you that Al was the driving force behind today's event in helping. And I'd like to just welcome him up, say a few words here. Get us started, Al.
Thanks very much, Tony. Pleasure to be here, and thank you for the opportunity to lead this effort for the New York chapter of HIMSS on interoperability. It begs an interesting question. Why did I agree to volunteer and lead this effort for the New York chapter on HIMSS and interoperability? I love New York, especially the civilized part of it, upstate. I love a challenge. I have a passion for HIT and health information exchange and their impact on community health. And I believe in volunteering to help the industry advance through HIMSS and other groups collaborating. So here we are. Excuse me? Please put your phone.
Hold on a second. Mickey Chupathy? Is that you? Oh, hold on a second. Hey, Al.
What?
It's Mickey Chupathy.
Oh, Mickey. Thank you, Mickey. Sorry for the last minute add to the agenda, but I just got an opportunity to be here. Just want to share a few things. TEFCA changes everything. We need governance for AI, but how is not yet clear. And have a good time here in New York today, and thanks for helping us push the industry forward. To get us started, I'd like to read a section from a New York State DOH grant, or GA. Medical technology has advanced rapidly in the past 10 years, from robotic and laparoscopic surgery to drug-coated stents. In general, however, healthcare lags well behind other industries in investment and use of IT. Financial services has invested 10% of revenues in IT, while healthcare is around 4%. HIT is key to meet the challenges of increasing costs and quality gaps of healthcare, but it can also provide better and more timely access to information and sharing along the continuum. The delivery of healthcare in New York State occurs in many different settings, from physicians' offices to hospitals and from Manhattan to rural upstate towns. There's a crucial need for timeliness and standardization of data to transmit relevant info to healthcare providers. The diversity of settings, along with increased mobility of patient population, requires that standards be put in place so those providers can easily and securely access healthcare information. When was this? This was from an RGA in 2005 called HEAL 1. Does anybody remember HEAL 1? Alex, I know you do. That's very relevant here. So that's when HIE started in New York. It was pure fun to have the opportunity to work with a small group of leaders throughout the state to explore the possibilities and set a path forward and make a difference. It changed my career because it was the first time I learned how my professional experiences can be applied as a volunteer to help smart, well-intentioned, capable, secure leaders have more impact on our communities by working together, and how fulfilling it can be. There was ambiguity and confusion in the industry regarding ways to address these challenges. I studied the first 9 connecting communities around the US, and I joined Connecting for Health. I brought leaders from our community to Boston and Mid-Hudson to meet visionaries like Mickey Tripathi and John Blair to learn and to figure out how we can get their guidance. This helped Upstate to initiate HIEs. I also learned about the power of convening stakeholders to solve common problems. At that time, providers had different visions of the value and best approaches to leverage data to be provided by the not yet developed utilities called RIOs. Helping health systems and other providers improve performance with data innovation, including data from HIEs, became a foundation of our company, SI. New York has come a long way. NICE, the QEs, their boards and members have built an amazing network of networks. HIEs that add a lot of value for a lot of providers and the patients they serve. I sincerely thank you all for all that you have done. So this wasn't me, and I really appreciate it. Then came other opportunities. We are far better than most other states, and it has helped me and my family personally as we all use the value of the RIOs. But after HEAL 1 came HEAL 3, 5, 10, 17. Many of you probably remember those as well. 17, oh boy. That's the last time I pulled an all-nighter, and it will be the last time I ever do it as well, as we led the grant application in a program for a community health system with a variety of EMRs and a need to enhance communication with community specialists, nursing homes, and home health agencies. It's important because the setting at the time was a different time than we are today. The Community Diabetes Collaborative received $6 million in state funding to build and deploy EMRs, HIEs, pop health, care management, patient engagement to serve 3,200 patients with diabetes. Working with Eric Jacob and a lot of the people from Rochester Regional Health, it was Unity at the time. It was the most fulfilling healthcare project of my career, as it leveraged the HIE and many other tech to yield a positive impact on outcomes. Why it's relevant today is the following. The common interop dilemma at the time was public or private. People remember that? People thought there'd be a silver bullet, pick one. We thought it was both, working in harmony. I remember vividly a sleepless night before our meeting with the state to justify why we needed a private HIE for the health system to connect to the public HIE. We needed data scope, granularity, timeliness, and quality that was beyond the capabilities of the RIO at the time. In fact, we worked very closely with the RIO to deliver the best interop strategy available through both Rochester RIO and DB Motion, a platform we use for our private HIE. The private HIE was incredibly valuable at that time and for many years. But interop strategies should change as needs and capabilities do as well. The health system migrated several EHRs to Epic. The services of the RIO increased value. The private HIE was retired for that particular use case. Other health systems still use them, and we need to figure out how to go about moving forward. Many providers have developed great interop strategies and capabilities, and I'm excited to hear about them today because we have some great providers here from upstate and downstate. The landscape has changed, and many of the problems described still exist. There's still ambiguity and confusion. What should health systems and other providers do now to optimize interoperability? That's the purpose of today. We have a great lineup of experts to share perspectives, bring clarity, and help each of us get smarter to contemplate the question. Standards, are more mature, EHRs are more mature, regulations, tech capabilities are stronger, HIEs, cures and TEFCA are real, QHINs are here. Needs and uses of data have also enhanced. We also have to find a way to enable secondary use cases that are valuable to society, like helping us come up with new drugs. We need to shift from a situation where a variety of utilities provide threads of connectivity and help us create a quilt that can cover all of our needs. I'm thrilled now to introduce our keynote, David Horrocks, CEO of New York eHealth Collaborative. There's no one better to summarize the interoperability landscape, federal regs and standards, direction, and approach of New York State, changes coming to the statewide health information network, SHIN-NY, and how HIE utilities will complement other solutions to build that quilt, to help providers build the quilt that works best for them. Following his remarks, we'll have a series of panels to provide context and information to help you design your quilt. One on existing interop tools, enablers, and capabilities, followed by a panel with 4 of the approved national QHINs, and then a panel with providers from New York City and the civilized part of the state, Rochester, to get their perspectives on designing their quilt. But first, David.
Well, thank you, Al. And Al asked me to on the topic of.
You can
Luckily, it fell down.
unused.
So thank you, and Al asked me to. Better? Yeah. All right.
Oh, better.
Asked me to speak just briefly for 15 minutes or so on the topic of TEFCA and other government initiatives to enable interoperability. And I appreciate the opportunity. It is such a good day to thoughtfully reflect on such topics. So I have 3 points, really. One is on TEFCA, status of that. The second is the state's efforts and the SHIN-NY. And then a third will be on what I think is a barrier for further progress. So we'll just jump in. So the first point is that TEFCA is gaining traction. And at the national level, I think it's where most of the action is. We've had national networks for quite a long time, and actually on a transaction basis, those other national networks, especially what runs across care quality, are still I think several orders of magnitude higher in transaction numbers than TEFCA, but I don't think that that will be the case for long. And I do think that paying attention to TEFCA is what we need to do. Now, most of you probably have a good grasp on how it works, but Zoe sent me a couple slides, and I thought I'd just run through a little bit of how TEFCA does work. TEFCA operates under the sort of auspices of what we used to call the Office of National Coordinator for Health IT. And since that was a mouthful, I guess, we made it the Assistant Secretary of Technology and Planning or Policy or something. So that is very catchy. So TEFCA operates under their auspices. They have contracted with a designated entity to oversee the network for them. That designated entity is the Sequoia project, where Zoe is and where I've had the privilege to be on the board for the last number of years. The RCE, Sequoia, organizes the policies and standard operating procedures for the network. Now, really, the heart of the network, you might say, are these organizations that directly participate in the network. They have to be qualified to participate. There aren't that many of them. There are 7, I guess, at the moment. And we call them Qualified Health Information Networks, or QHINs. And a good number of them are in the room today, and I'm sure we'll hear from them shortly. The QHINs themselves have signed up participants. So he tells me there are 112 as of a couple of days ago, participants that directly work with the QHINs. Some of them are networks themselves, and there are another 1,600 or so sub-participants in the network. So did I get all this about right? So, okay. So in TEFCA, if you were familiar with Care Equality and that network, which in fact Mickey Tripathi was very instrumental in getting off the ground, this is functionally very, very similar to that network. It is, however, government endorsed. It's government endorsed because we passed a law, or the Congress passed a law in 2016. We were talking about this in December of 2016. One of the final bills of the Obama administration, that was the 21st Century Cures Act, that directed the ASTP, formerly ONC, to either start or support a network that would serve this purpose, and they decided to start one. So if you're doing the mental math, that's 8 years. This is not quick work. This takes time, and it will continue to take time. I will admit that I've been maybe a bit optimistic on timeframes for our national network progress, but I do believe it is an inevitability, and that progress, barring something unexpected, big changes in the direction of one of the future administration, I think that it is an inevitability. So I included a picture of these are all of the QHINs. As I said, some of them are in the room today, and we'll hear from them. I'd say they each have different strengths, and they bring a different basket of services to the market, but all of them can move and transport data equally well. TEFCA, the Trusted Exchange Framework and Common Agreement, is primarily about the movement of data. It is not in and of itself about the aggregation of data, but QHINs are, at least some of them, do aggregate data and provide analytics services and do other value-add things on top of it. So an observation I have about our current state is, and this is very much an opinion that others might debate, one of the reasons I think that TEFCA is an inevitability is the support that we're seeing from EHR vendors. And I think that's crucial to the adoption. I think it's crucial to the workflow friendliness that clinicians or care managers or others will experience in using the network and in interoperability tools. And we are seeing, even in the last week, several announcements, I guess, that demonstrate that the major EHR organizations are backing TEFCA. So I think that is a harbinger that broad participation will come, even if it does take a bit of time. One more thing that on TEFCA that I think is important to understand is that the purposes that we can use the network for are limited, but growing. And the major purpose that people use the network for today, of course, is for treatment. If you are paying close attention to the trade press, you know that what treatment means is not exactly the same between maybe one organization and the next. And that is an issue that I think we do have to resolve as an industry. And that'll be part of the point number 3 in just a minute. Just recently, we've seen some additional purposes that have been approved. These are approved as, what do we call them? Exchange purpose SOPs, I guess. So the public health SOPs have just been finalized in the last few weeks, and that's very exciting, very important. Not all of the finalized purposes are required. And I think this is also a very important point to understand. If you participate in the TEFCA network and you receive a request for treatment, you have to respond to that. You're obligated under the terms of your participation agreement that probably flows down from your QHIN. For some of these other purposes that we're building out at the moment, you're not required to respond. And I think we can probably guess that until we're required to respond, the network won't live up to its full potential, and that because many will not. So we're making progress. 8 years in, I think it will continue to be slow. EHR vendor support, I think, is crucial and makes this an inevitability. Have to work hard on these standard operating procedures and these exchange purposes. That's my TEFCA point. And I'll move on now to state efforts. The New York eHealth Collaborative, we are contracted by the state. We're the designated entity for the state to oversee the work of the SHIN-NY, which I'll describe how the SHIN-NY works. Most of you, again, probably know that. The SHIN-NY, like TEFCA, is not an organization per se. It is a network in which organizations participate. The business end of the SHIN-NY is organizations that have been qualified as direct participants. We call them qualified entities, or QHINs, and there are 6 QHINs in the state, at least one of which is in the room today. There are participants that work underneath of those QHINs, and there are about 19,000 of those participants. QE, what did I say? QHINs? All right, that was a Freudian slip, and I'm going to show you why. The purposes for which the SHIN-NY was established also began with treatment purposes. It was that clinician who was in front of a patient who needed medical history. That's the stuff that really got people excited in the beginning. But those purposes have also been expanding. And I'd say that public health purposes are increasingly very important. They're a lot of our focus. Supporting the NYHER 1115 waiver that our Medicaid team is rolling out is one of those what I would deem a public health purposes. Now, as I describe this structure, some of you are like, this sounds familiar. And that is true. I think that the governance model that was adopted federally is very similar to what New York had been using and was in place. We have our version of a national coordinator. That is Ann Skatine at our Department of Health. We have our version of a designated entity, and that is New York eHealth Collaborative, where I work. We have our version of QHINs. They're QEs. Very easy to mix those two together. So our QEs do a lot more than move data, though. They are all data aggregators, and they are all doing value-add things on top of that data. They do, sure, they move a lab result from point A to point B, but increasingly they are helping a practice that's in a medical home understand their performance vis-a-vis their peers. They are delivering notifications about hospital encounters to care managers. They are supporting public health purposes, and we'll probably hear a little bit more about that today. All right, so where are we headed with the SHIN-NY? We said we are modernizing. We are working hard to modernize, and we have 3 strategic priorities in the modernization. And these have been given to us by the Department of Health and also with the input of many stakeholders, including some of you in the room. Our priorities are first, statewideness. We need to be able to provide seamless statewide services across the state of New York. The SHIN-NY is very good at serving communities. We have these 6 regions with our QEs, but when we have to try to pull the data together for something like the 1115 waiver support, or we're right now practicing aggregation of the social determinant of health screenings that will be a big part of that waiver. That's not a strength of the current model. We're modernizing to fix that. We are secondarily trying to get more efficient, and we're trying to get more efficient at the movement of data so that we can put more of the resources into the value add that happens on top of the data. And then the third priority is, you could say, continuing to support communities. We're going to continue to have a QE-centric model for the SHIN-NY, where we build on the strengths of these regional organizations. So as with TEFCA, that after the Obama administration passed it, it's like 8 years on, we're still working. It is slow, it is hard. That is also true for reform of the SHIN-NY, putting new policies in place and trying to shift the way that we work. In a thumbnail, though, of what we're trying to do with reform here is on the screen. We are trying to free the data and not have these sort of regional repositories where a participant has to only work with the local crew because they're the only ones that have access to the data. We want participants to have choices. They can choose any of the 6 QEs, and that QE would have access to the data necessary to serve them. They could work with a second or a third QE for services that they are good at. And this is how TEFCA works. There are no separate regions where you have to work with the New England QHIN. No, QHINs have access across the board. Reform is going to facilitate those statewide services I described, such as the 1115 waiver, but there's many more that we want to support. We want to support the epidemiologists when the next, and it is inevitable, right, the next public health crisis or emergency hits in New York. We want our epidemiologists to have quick, accurate access to information, population health statistics, and information that's what I would call hydrated or uplifted, meaning there are reportable conditions, and we do manage to get those reportable conditions up to our public health officials, whether that's a respiratory illness or other infectious diseases. But uplift would say we're delivering this respiratory illness information with chronic condition flags like asthma right on that report, so that our public health officials can understand and react more quickly. So the reforms, I believe, will be very good for participants. Will be very good ultimately for patients, and they are now required. This move is required in regulation in New York. So I have a slide. I'm not going to try to get into the particulars of this, but there's so many elements to trying to reform. We have to move to a single statewide participation agreement. That's how TEFCA works, right? There is a CA and TEFCA, the common agreement, and we need the same in New York. We need to have a common agreement that we work from. We need to have a single consent registry for patients so that today, most of the consent happens in 6 separate repositories. That needs to be statewide, and we're working hard to get there. We need the gateways that NICE operates that help the QEs move data between each other. They need to be much better. We need to define what is core SHIN-NY data more accurately so we can improve the quality of what's submitted and what's available to participants. So all of those things are in flight, and I hope that you will see exciting things in the SHIN-NY soon. So I have one more point. I have enough time for one more point. Yeah. So, and that is what is holding us up from better progress at a national level and at a state level? And I think it is the privacy of patient data, both at the individual level and at the aggregate level, which you might really say a data use question. We have not solved this as an industry, and we have to. I have a picture here that is a conceptual model, if you will, of where I think how I think we can protect patient data in the exchange of information. Really, there are three places where one might do this, right? There's the requester. You can make sure there are policies and rules around making a request for information. There's the intermediary that's moving it. You can have policies and protections there, like a global opt-out, for instance. And then there's where information is held or originates, and you can have rules there. And the SHIN-NY has focused, where has the SHIN-NY focused on those three places? What?
The intermediary?
The SHIN-NY is the intermediary,
Yeah.
but our policies for protecting patients have been at number one, believe it or not. It has been really focused on the data requester. You have, before you're allowed to ask for your patient's information, you got to get them to, like, a wet signature on a form. And that form then has to go into a registry, and now you're allowed to peek. I think it's the wrong place. I don't think that's the right way to protect patient privacy. It creates burden for providers. It creates confusion among patients, and it doesn't do anything for bad actors. Like, if you're just going to attest, oh, I got the signature, like, that's, and you're a bad actor, that does nothing. It's like asking at the door to the store just to confirm you didn't shoplift. Like, it doesn't do anything. So we need to fix this. What does this mean for I have a picture. You're going to understand what this picture is. You've all experienced this. This is what consent is. Well, we are relying on something that is not meaningful. It does not protect patient privacy. I know you've all experienced this. You go in and you sign 3 times. You have no idea. That is not an informed consent. That is not a process that's me. Why are we doing this? Why? It was just checking boxes. We have to do better than this. So this is what, if you really care about privacy, with the theme of the day, this is what this means for patients. So in my opinion, this is not addressed nationally very well. I know that's not an opinion shared by everyone, but I don't think we've addressed this nationally. I don't think it's well addressed in TEFCA. I think we should solve this in New York State and apply it to TEFCA too. We should give patients the right to, at that point of release, a patient should have the right to say, don't share my data, other than the normal health operations, don't share my data elsewhere. That should be a right that a patient has. And in the case of sensitive information, and everyone's very concerned about sensitive information, honestly, post the Dobbs ruling, that choice that a patient has should be a very carefully administered choice. It should be an opt-in choice, probably. But in other instances, it perhaps is an opt-out choice. Let's make this easier for patients, but give them a real understanding. At the point of exchange, we should give patients a global opt-out opportunity, and they do technically have this. But for it to work today in the SHIN-NY, they'd have to go 6 places to opt out. And then that doesn't count the QHINs in TEFCA, and it doesn't count the other national network activity. Patients should be able to do it one time, and boom, I don't want you to do this. I want it blocked. That is a patient-friendly thing that we should implement in the state. And when we do that, when we get all of our networks hitting against a common consent registry, we can also create a log of each of those information releases, and we call that an accounting of disclosures, right? Or just a report for a patient, how your information was used. Not many people ask for these in my experience, but some do. And they should be able to get that one time for the state. Let's implement that. And then that first place where we put all this energy of collecting forms, let's stop. Let's say if you've given consent for treatment, then your doctor, your care manager, your clinician can request the information. We'll protect it at these other points. So that is my those are my 3 observations on government support of interoperability, Al, and happy to turn it back to you in the panel.
Thank you very much. Better.